Okay, so my name's Dawn Sanders. I'm making this video really for my dad to explain to him how proning patients helps patients who are in ARDS, and while we're doing it on our COVID patients. But just as a little introduction, since people may see this that don't know me, my name's Dawn Sanders. I'm an ICU nurse. I've been a nurse for 10 years in the ICU here in North Mississippi. And this is the best way I know to explain while we're proning our patients. So to start out a little bit on the pathophysiology of what ARDS does to a patient's body. And ARDS is acute respiratory distress syndrome. And it's really it's an inflammatory response that the body has to the infection. So when we're talking about ARDS, we're talking about pneumonia is your source of infection. And then with these COVID patients, we're talking about the coronavirus being the source of that pneumonia. So when a patient develops pneumonia, the body has this inflammatory response, and where it kind of shoots white blood cells and whatnot to the area of the infection to help heal the body. It's that inflammatory response. It's the first line of defense, really, in getting past that pneumonia. So what happens in the inflammatory response is the blood vessels dilate, so they get bigger, so you have more blood flow to that area, because they're trying to streamline white blood cells to that area. And then also you have increased capillary permeability, meaning that what's inside the vessels can get outside the vessels more easily. So not only is it shooting the white blood cells that are going to help fight the infection, but you can't just shoot the white blood cells. And with it comes other things, comes fluid, other blood particles and whatnot. So you get swelling. And it's not just pneumonia that you have this response for. You twist your ankle, that's why your ankle swells, because of that inflammatory response. You get, a bee sting, and it swells up because of that inflammatory response. This is the body's natural way of healing itself, of getting what it needs to the area that needs it. So when you have a patient that has gone into ARDS, that inflammatory response has happened, and so all this fluid and whatnot has gone to this area, and it's just kind of sitting there. So the problem with that in the lungs is that if the lungs have filled up with fluid, then you're not able to get what we call gas exchange. So the way the body works, when you breathe in oxygen, and you breathe out carbon dioxide. Pretty much everybody knows that. But that gas transport takes place in the lungs. So in the lungs, you breathe in through your nose, through your mouth, goes in through your air windpipe, into your lungs, yada, yada, yada. The little places that gas exchange happens is called the alveoli. And pretty much everybody describes them. If you looked at them under a microscope, it would look like little clusters of grapes. And then that's the blood flows over those alveoli, and that's where that gas exchange happens. The oxygen comes in and the carbon dioxide goes out for you to breathe it out. So when you've got the inflammatory response and you've got all this gunk built up in the lungs, that gas exchange isn't able to happen at the alveolar level because it's all covered up and gooped up with gunk. So we prone patients. And I tried to make a little visual to make this a little easier to understand, but being quarantined, I able to really go to the store, use what I had at my house. So I tried to make like a snow globe type thing, but I didn't have very much glycerin, and I got brown rice. But hopefully this will do what we need it to do to kind of help you understand. So if this is the patient, this is their head, this is their booty, this is their face. So this patient is laying face up right now. All of this down here is the result of the inflammatory response. It's mucus, it's fluid, it's stuff that has built up in the lungs while the body was trying to heal itself. So if the patient is lying flat and these are the lungs, then you see it all. I mean, gravity works. Everybody knows how gravity works. So gravity pulls everything down. So it's pulled that mucus to the back side of the lungs. So the front part of the lungs are really doing all of your work right now. They're trying you to do all the gas exchange that the body needs to be able to work properly. And patients decompensate because the lungs can't do that long term. That's not how they were built. The body can do wonderful things, but it has limitations. So we turn patients, not just ARDS patients, we turn all patients in the hospital. If they're not able to turn themselves, we turn them for them. Generally, when you turn somebody, put a pillow behind their back or even maybe a wedge behind that back, you're probably getting a 30-degree angle max. So I'm not sure the best way to show you this. I'm going to turn it this way and see if this shows. So say we're going to turn our patient, just our regular patient, we're going to turn them, put a pillow behind their back. You're getting maybe that degree of a turn. So you see all that mucus is still, it's still there. It's still clogging up the whole back side of the lungs. You've not made any progress. If you could see real close, you could see that some of the rice has gone this way, but not really much of it. So normally we tilt our patients, we turn our patients, put a pillow behind them, at a minimum every 2 hours. So you would sit this way for 2 hours, and then you would go this way for 2 hours. So you're not really getting a lot of mobilization of these secretions. So when you take a patient and you turn them prone, hopefully this works good and you can really see, you're completely taking them from face up to face down. So here we go, face up, face down. So then you see how all that mucus has now settled. So the patient is face down now. So now it's the front part of the lungs that is being clogged up with the mucus, and the back part of the lungs does not have all of that clogging it up. So what that allows us to do is it allows the alveoli in the back of the lungs to be free of that gook for a while, and allows them to open up and have that gas exchange. And so basically we call that re-recruitment of alveoli. And there are other ways you can do it when you have a patient on the ventilator. You can do different things with their ventilator settings, but that's more technical, and this is not really what this video is about. So we prone patients. Now, in America, we are very lucky. We have a bed called a rotoprone bed that enables us to prone our patients. It kind of looks like a cross between a rotisserie, a chicken rotisserie, and a spaceship. And I don't work for Rotoprone. Rotoprone's not paying me any money, but rotoprone beds do such wonderful things for our patients when they are used appropriately. So the thing though is there are only so many rotoprone patients, and rotoprone beds, and we have thousands of patients in America right now that would benefit from proning because of their COVID pneumonia. So we are manually proning our patients, which can be done safely. There are lots of instructions and education on how you can prone patients safely manually. And so we are doing that in our hospital, and other hospitals around the nation are doing that right now. And we're doing that to kind of help. So when we are proning our patients, we're moving those secretions around. So not only does it help us re-recruit those alveoli, but when you mobilize those secretions, it allows us the ability, when you move those secretions to different areas of the lungs, it allows us to be able to get in there and suction some of those secretions out. So that's kind of the two-part reason that we prone patients is secretion mobilization and re-recruitment of alveoli. I hope this video kind of helps you understand why we're proning our patients, and the wonderful benefit that it has for our patients. Thank you.